Hi, my name is Josh, and I worked on a project called A Novel Approach to Quantify In Vivo Knee Cartilage Stiffness for Osteoarthritis Diagnosis. Osteoarthritis, or OA, is a degenerative joint disease that can cause altered joint range of motion and a lowered ability to bear weight. It's manageable by medication or surgery, but causes irreversible damage that the body cannot naturally heal. Overall, it leads to a decreased quality of life with pain and mobility impairment. Importantly, one of the changes caused by OA is altered properties of articular cartilage, the tissue responsible for smooth articulation of the knee and weight bearing. There are numerous risk factors associated with developing OA. In fact, you're twice as likely to develop OA if you're female. Traumatic injury, such as a torn ACL, commonly seen in athletes, makes you 1.5 times more likely to develop OA. These reasons, among others, cause OA to affect about 10% of North Americans. To diagnose OA, doctors will usually confirm symptoms such as increased knee pain by taking an x-ray of the knee. Late-stage OA is super easy to detect because your cartilage has degraded and the joint space has narrowed. However, it's not an ideal time frame as treatment options are instantly limited. The issue with detecting early-stage OA is that it looks very similar to a healthy knee in an x-ray scan. And this is a big issue because the early stages are the only time that preventative treatments are effective. So we need a way to differentiate between healthy and diseased knees to diagnose early-stage OA. The Movement Assessment Lab at the McCaig Institute has proposed using the dual fluoroscopy system, a complex instrument capable of taking x-rays, motion capture, and ground reaction force data simultaneously. The combination of the data collected can be used to calculate functional properties such as cartilage stiffness, a property of cartilage that changes as a result of OA progression. The purpose of this study is to develop a novel method of quantifying in vivo knee cartilage stiffness. Stiffness is governed by a relatively simple equation, force over displacement. In this case, our force is joint contact forces in the knee, and displacement is cartilage deformation as a result of those forces. We can calculate two values of stiffness, instantaneous, which is a single point value of stiffness in time, and transient, which is the slope of the linear region of the force displacement graph. To find forces in the knee with the DF system, I first tracked motion capture data by assigning labels to motion capture markers placed at certain anatomical landmarks along the leg. This enabled me to calculate geometric properties such as the center of mass of different sections of the leg. I then combined the motion analysis data with the ground reaction forces to get forces at the knee through an inverse dynamics code that I helped develop. Next, the two X-ray transmitters and receivers were used to find cartilage displacement. These instruments essentially take an X-ray video of the knee from two different angles. Our lab created 3D models of our participants' knee tissues from CT and MRI scans. Then, because there's two angles of X-ray video, we could register the movements seen in the video onto our model and measure displacement from the small compression we see over time. With forces and displacements found, I calculated both types of cartilage stiffness. We used two groups for data collection, a healthy control group and a group who had undergone ACL reconstruction surgery, or ACLR, making them more likely to have developed early OA. We took CT and MRI scans to get our 3D model, and then did a 10-minute loading test on their dominant or injured leg with the dual fluoroscopy system. So here's our first batch of preliminary results. For instantaneous stiffness, this suggests that the healthy group had stiffer cartilage, which makes sense if you consider the degradation that OA causes. At steady state, the diseased cartilage deforms more with the same force applied. For transient stiffness, we see the opposite. We see that the ACLR stiffness is actually much greater than healthy cartilage. This change was not expected, and further research on a larger sample size is required to determine if these results are actually representative of the larger population. So these initial results suggest that the changes to cartilage stiffness due to OA are observable via this method. However, we are severely limited by the small sample size as well as male exclusion, which are both areas of future research, which are currently being worked on. Like any study, we could be affected by subject variability and analytical calculation errors. Although we lack enough data to make any significant conclusions, these initial results are promising of a method that can detect differences in knee cartilage stiffness. This study could contribute to the implementation of this method into clinical settings and help improve the quality of life for those susceptible to OA. Here are my references. Thanks for listening.